So this first patient is a person that is being treated for COVID pneumonia, and I'll show you a series of radiographs. So this one is on the 15th. This is the 15th. Here we now see that we have pneumomediastinum that is new, and air traverses the thoracic inlet into the soft tissues. This is the 18th, in which we see pneumomediastinum. In addition, there is air in the upper abdomen here. Here is on the 17th, give you a feel for the amount and the location of air in the upper portion of the abdomen. So how might we potentially connect the air in the upper abdomen and the pneumomediastinum? Here is a CT, and I've shown one of these before. This is again a nice example of this. So when we evaluate the air in the upper abdomen, we can see that it is primarily located anteriorly, and you can see the extent of it in relation to the diaphragm. We also have small amounts of air in the retroperitoneal fat in the posterior pararenal space. So this is very consistent with anterior abdominal pneumo-retroperitoneum. And the way the air gets there was described very nicely in an article back here in the 1970s, where this person nicely described the passage of air in relation to the costal and sternal attachments of the diaphragm. And there are places there through which the air can go, the sternocostal triangles and the foramen of Morgagni, and describes that in the anterior abdominal wall, between the transversalis fascia and the parietal peritoneum, there's an anatomic space, extraperitoneal fat, continuous with properitoneal fat and the posterior pararenal space. So this is a very nice demonstration of that pathway, and a particularly nice image to show if you're teaching this is the air in relation to right here, the sternal and costal attachments of the diaphragm and the foramen of Morgagni right over here at this level.
So Howard, we just had a case identical to this, same history, and yeah, they were questioning us about where the gas was coming from because the patient had a pleural drain in for a pneumothorax, but we thought it was all coming from the mediastinum and tracking elsewhere.
Right. Yeah. Interesting that these guys here described this really nicely on radiography in 1978, and you can see they've got some cadaver specimens for the anatomy and described it particularly in the pediatric age group, as you can see there. So even in the pre-CT era, they nicely worked out the connection between pneumomediastinum and extraperitoneal air in the abdomen. So sorry, Jeff, you said you had the identical case and you had the same explanation for the clinician.
Yeah, we didn't have a more recent abdominal CT, but we did see some pneumo-retroperitoneum on an earlier one, and there's pneumomediastinum and a lot of subacute gas. But same history, COVID with stiff lungs, had been on the ventilator recently.
Yes, yeah.
Well, that was a perfect explanation, thanks.
Yeah. Here is something that we're starting to see more often. We have a lot of patients here, even non-COVID patients, that require ECMO for various reasons. For example, veno-arterial ECMO, I've seen it before. In this patient, as you'll see, this patient later on, and I'll go here from the 10th to the 17th, now is being treated with a dual channel single jugular cannula, veno-venous ECMO. And you can see that progressively over time, I'll show you that aeration of the lungs just disappears. And now we're at the point over here, certainly here, when we have really just no aeration of lung. So the notion of so-called white lungs of ECMO is sort of a known thing. It has been described in the context of patients for various reasons on veno-arterial or central ECMO or peripheral ECMO. And this is a patient that really has non-aerated white lungs. And, she's being treated with that. You can see at one point in time, close to around this time, the tidal volume actually given is very small. And the prognosis presumably is rather grim. So just the white lungs. You don't have to have obstructive atelectasis, as you can see there. It's presumably just consolidated edematous and eventually just not aerated lungs. Okay, this one is just for your interest. So this patient has a rather complicated history. The most relevant recent history is that he had a surgical procedure to close an open sternal wound. So we do not have sternal wires. And I think he's had a total of 2 surgical plastic procedures, the most recent of which used tissue here in part to fill in the sternal incision. But when I was looking at that, I noticed, and I was a little bit intrigued by the fact that I could tell what each device was initially, except for this thing right here. And I'll show you that that thing is associated with very small leads in this particular location right there. And that turns out to be located in relation to the surgical procedure. And we can see, let me see if I can pick out that portion of the small little guys coming in like that. But what that device is a so-called Cook or Cook-Swartz Doppler blood flow monitoring system. So they monitor the perfusion of the flap that they have put in using this device. And you can see how it connects to a very small artery or vein in order to monitor the perfusion of the vascularized flap that they have used for the procedure. So just to clarify what that item is, I've seen that before in the context of neck surgery for head and neck surgery for tumors, but the first time I've seen it used in this particular occasion. So it just clarifies what that is. This is just a kind of a fun case. He's a trauma patient, MVA kind of rollover, and rather easy to see pleural air here, and there is a little bit of air on the left side. But I was having a discussion with the resident as to what this line is. It's a bit unusual, but we see pleural air on both sides. And then I wondered if somehow this is air medial to the left lower lobe, just by chance, but wondered about that. But then, of course, we had a CT soon after just to clarify that we actually have an anterior junction line, but it's not a junction between the 2 lungs in the midline, but between air in the pleural space in the midline. So just a curiosity where we form a line right here between air in the anterior pleural space, and it's a little bit to the left of the midline. So just a curiosity, the distribution of air produced a junction line between pleural air on both sides. That's all that was. Unusual.
That's nice. That's a really cool example of that.
Yeah, unusual. Okay, I've shown you this one. I showed you the edema one device. This one is just a little bit of a curiosity, nothing too special. This is just a situation after lung transplantation. I don't know the etiology of these opacities. I think they're areas just of atelectatic or scarred lung. But what is a little bit interesting is the fact that we can see a bit of air right here in the chest wall, and a similar finding on the other side, but in exactly the same place in the chest wall. So there is a little protrusion of lung, transcostal herniation of lung into the chest wall. Because of the symmetry of it, one can reasonably surmise that we have the clamshell incision that goes like that and like that. And in relation to the lateral portion of the clamshell incision, we have no really restraining intercostal muscle. So there's just a little bit of a transcostal herniation in those two locations, again, post-surgical. And I don't know if the surgeons here use a particular technique, but I've seen this a few times where, in terms of the lateral incision, there's a little bit of thinning of the muscle. And that allows the lung to herniate a little bit into the chest wall, as you can see there in that location. Have you seen that before, Jeff, at your place, where,
Yes.
or anyone else, in relation to the incision? That's what I
Yeah,
ascribe it
quite
to.
frequently, especially in some of the lung transplants when they do those clamshells.
Yeah, you see there's very little intercostal muscle there, like right there.
Yeah.
So just a curiosity.
And I've seen a few on radiographs, like if they come for just post-op or clinic, you can see that hernias are dynamic.
Okay, yeah, there. Okay, good. Those are my cases.
Thank you. Those were all great. Travis, do you have any cases?
Give me a couple minutes here.
Yeah, no problem. Let's see, Peter or David?
Yeah, I have to.
I'll make.
So this was a case shared to me by my colleague Alice Hamid, who recently joined us here. I thought it was a really nice case. So I'll show the this interesting scout image, and you can see this abnormal contour here of the right heart. And here's the CT images. Here's the contrast. You can see the outpouching here. Maybe it's arguably actually better seen on the maybe on the non-con also on the calcium score. So if you follow it down, you can kind of see the pericardium here, and then you kind of lose the pericardium. So this is this outpouching is from a congenital pericardial abscess, partial congenital abscess on the right side, which I hadn't seen a right-sided absence there. So this patient was coming in he was referred from some other hospital. We had no notes on him. The only information we knew was the indication, which was chest pain.
And no previous procedures, right? This isn't a surgical.
No. And then he also had no, this is most likely congenital. He also had a scan at our hospital from 2013. It was the exact same thing, so it's unchanged for a long time. But one, Oz and Art, they both suggested that this could be his chest pain, because they looked up there are case reports of this type of herniation causing dynamic torsion and potentially occlusion of the coronary there. So their idea was that this might be might be some occlusive stenosis or like dynamic stenosis of this RCA there. Unfortunately, we didn't have more than one phase because it was just prospective. And then a few other incidental interesting things on this one. They're sharing the inferior pulmonary veins. They're sharing a common ostium here, and couldn't really find a the minor fissure. So the middle lobe may be kind of hypoplastic or just very compressed from that herniation. But
And
have you guys seen a defect like this on the right side? Because we
never.
show them on the left, right? Is that? Yeah.
Yeah, I've never seen one like this before. That's odd.
And the other one I have kind of is similar to what Howard was showing. But, so 30-year-old patient with COVID, and you can see severe COVID pneumonia, opacities everywhere. This lucency here is kind of interesting. And when you look at his CT chest, he has obviously acute lung injury from COVID, but notably there's a lot of pneumomediastinum here. He's not intubated. This was right after he was admitted. He has air in his soft tissues, and so and then if you look carefully as you go down, you can see these lightning bolt type of low densities here. So nice example of interstitial emphysema.
Can you zoom that up? That's nice. In the medial basal segment.
Yeah. So you can see it here.
You know, one of the interesting things here is that most of the air is actually in the pericardium, isn't it? I mean, this is pneumopericardium.
I'm not sure, right? Because this is pneumomediastinum here. So I don't know how you can, I'm not sure.
Down. Go down farther. That big broad band that's farther down.
Yeah, I mean, this looks like, yeah, I mean, this, yeah.
That is pneumopericardium, right? The pericardium's on the outside of that gas collection. So he has both. I mean, he's got stuff in the mediastinum outside the pericardium, but a big component of pneumopericardium itself, I think.
Can be hard to say.
And so all it has to do is track up those pulmonary veins, and he can go all the way back into the pericardium.
Yeah, but this doesn't really make sense then, right? Was this lucency here is going anterior?
Yeah, so it's
pericardial.
Beyond, yeah, it's beyond the pericardium, but there is a pneumopericardium component.
Yeah, and then there are probably little strands here which we can't see, but yeah, it definitely follows pericardial contours here. The interesting thing is that so I talked to the nurse, to the clinicians. This wasn't from line placements or anything like that. The patient had, but they hadn't been intubated. So this was interestingly from BiPap, most likely from the positive pressure from BiPap. Typically, we've seen this quite often from invasive mechanical ventilation with positive pressures, but BiPap can also do that less commonly. That's it.
All righty, thanks.
Okay, Jeff, I'm ready now.
All righty.
All right, you should see a Roentgenogram.
We do.
And yeah, this is a trauma patient. You can see they're in a neck brace and they were in a motor vehicle crash. I'll let you look at it for a second, but hopefully everyone's eyes go to this area. And, you know, I don't know, I think our residents oftentimes focus purely on this concept of just superior mediastinal widening. But notice in this case, you've lost the normal definition of the aortic arch. You can't really see an AP window here. You can't see the left pulmonary artery. And maybe you can argue there's a little bit of inferior depression of the left main stem bronchus. But anyway,
Yes.
there's a clavicle fracture. Howard, go ahead.
No, yes, I was just saying yes. Yeah.
Yeah, so this person has bought themselves a CT and their trauma was sufficient enough that they were already going to CT, but even if they hadn't, you know, this would be enough to raise concern. And sure enough, you can see there's mediastinal hemorrhage surrounding the aortic arch. And when you look, you'll see in the proximal descending aorta, there's a subtle intimal defect here. So I think this, fits with a minimal aortic injury, or just one of these grade 1 injuries just involving the intimo or intimomedial wall, since there's no external deformity. And there's all of this hematoma here. There's no sternal fracture to account for that, and you've lost the fat plane around the aorta. But as we keep going down, you will see there's hematoma. There's a little less hematoma here, and then you've got more hematoma surrounding the descending aorta. And towards the diaphragm, right in here, there's a subtle, regularity to the wall of the aorta. So I suspect that there's a second injury here. But what I haven't seen before, and this is new, so we haven't had follow-up yet, and I have not actually seen this in real life, but notice all the hematoma that's around the liver. And I think this is below the diaphragm, most of this. But check out the configuration of the inferior vena cava and how there's a full-blown traumatic injury of the inferior vena cava as well. And it's peculiar because it's contained here, but I guess it's a very low pressure venous system that it hasn't, it obviously is extravasating into this area surrounding where the normal configuration of the IVC. But I have not seen traumatic IVC injury. Certainly it has been reported, but you can see here on the coronal what this looks like right there.
Wow.
So I don't know what they're going to do about this, honestly. There's a little bit of perisplenic hematoma, and we didn't see any active extravasation there. They were thinking about anticoagulating for the minimal aortic injury. I don't know if that's necessarily, prudent in the setting of the IVC injury, but yeah, that's the new finding for me right there. Does anyone have experience with these?
I've seen
No,
one,
yes.
Travis, and it was fatal.
Yeah.
It was more of it wasn't contained, it was more of an avulsion, because you imagine everything just from the belly just pours out.
Yeah. And here, sorry, and so this actually looks like it's a, still mild on the traumatic aortic injury scale, but this one actually, it looks like there is a little, defect in the external contour of the aorta, as opposed to that one up higher.
Right.
And I don't know about this right here. I was wondering if that's just a little intercostal artery, but this patient will certainly get followed if they,
I'll show you my
if
case
it's
when I show cases, but it looks similar.
okay, great. If it's not fatal. And then this is just a quick one, but it's, you could see this, I don't have a radiograph. This is outside, and this was actually incidentally discovered apparently on a cervical spine MRI or CT, where they got low enough to notice that there was something in the chest and worried about lung cancer, got a CT. You can see it's in the right paratracheal region. And here we see, we've shown, I know I've shown and David has shown, like large nerve sheath tumors that kind of descend along the paratracheal region. This is lower down, right at the right tracheobronchial angle, and even indents that right main stem bronchus a little. And there's some areas of calcification along the dependent portions. Now, I don't know if this is milk of calcium, if it's just layering in here, or if it's actually calcium in the wall. There might be a fleck right there. But they did take this out, and this was a foregut duplication cyst in the right paratracheal region. The other thing that's interesting, and you can see it on lung windows, maybe you saw it going through here, there's this little divot or this little bump in the posterior aspect of the trachea. And so this was followed, I think on the initial scan, this was an outside scan. I don't know if it was not detected or thought to be mucus or whatever, but they did on a follow-up after resection of the bronchogenic cyst or foregut duplication cyst. This actually was still there, and they went in and snipped it out. Anybody want to guess what it is?
Oh gosh, no, I don't know.
Well,
A,
it's
a
arising
primary
from the,
tracheal lesion?
what's that, Howard?
Sorry, a primary tracheal lesion, or is it connected to a
Yeah, and
vessel?
it's arising from the posterior membrane or from the trachealis muscle. So yeah, it's just a little leiomyoma. That's what it was.
Oh,
So smooth muscle, and it's stained for smooth muscle markers. So arising from the membranous or muscular portion of the tracheal wall. So just a cute little incidental finding there.
it's a good observation to even see such a small thing.
Yep.
Yeah.
So, all right, Jeff, those are my two for this week.
Awesome. Thanks. All right, David, do you have any cases?
Yeah. So let me get to it here. Here we go. So I hope people can see a large pneumothorax. This is an 18-year-old man, spontaneous pneumothorax. He's got a little, probably blood or fluid here in his pleural space at the bottom. And the right lung seems to be tethered at the apex here. It's not able to collapse back to the hilum. So there's probably a little adhesion up there, and it might be a adhesion that tore. So at any rate, they put in a drain, and this is immediately after drain placement. You can see the pneumothorax has been reduced, and there's mild diffuse lung disease. So at this stage, right after re-expansion of the lung, this is probably just microatelectasis. The lung isn't going to be able to expand fully right away. There's been absence of surfactant for a while with the collapse of the lung. And so some microatelectasis could account for this. But that should clear up with time. But instead, things got much denser. So here's just a few hours later, you can see that the abnormality of the right lung is getting worse, not going away. And the next day or later on, it's even worse. And it started to decrease after a few days. And the current radiograph is here. You can see that it's all pretty much gone now, so it's faded. So this is an example of re-expansion edema, which is really a kind of alveolar damage. We did get a CT scan a few days after this had developed, and you can see that it doesn't really look like lung edema. It's really it's a patchy abnormality. There are not a lot of septal lines to go with ordinary watery edema. It's a patchy, lung injury pattern. The interesting thing is these people often are sicker after this re-expansion edema has developed than they were when they had the big pneumothorax. You'd think that getting rid of the pneumothorax would make them breathe better, but if they get re-expansion edema, they can actually have more respiratory distress. And the reason is because this is alveolar damage, there's cytokine release. You can even affect the function of the other lung because of all the cytokines. You can get edema on this side because of circulating stuff. So this is it's a kind of toxic situation. People are often more symptomatic when they get this re-expansion edema than they were with the big pneumothorax to start with. So it's one of the few times I've managed to see a CT scan in the setting of re-expansion lung edema. So he's doing better now. And I think the CT also shows, as we get toward the apex, what the source of his pneumothorax was. He does have some apical blebs. You can see some of these are right on the edge. And there's some adhesions here in this right lung apex. And we even have a bulla out here in an adhesion, probably. So one of these things popped on the surface of the lung, led to his pneumothorax. So typical age, 18 years old, 18 to 22, something like that is typical, usually tall, slender people. The interesting thing is that, Seattle has a big Asian population. In the last 5 or 10 years, the preponderance of people that I've seen with spontaneous pneumothorax have been Asians. And, it used to be, Asians have gotten taller. Japanese people are 4 inches taller than they were in the 50s. And so I think with changes in diet and, maybe more protein in the diet, more fat in the diet, people are growing more. And so I think I'm just speculating, there are a lot more tall Asians. And so there are a lot more young men who are, tall and, lean, which is the usual setting in which you get these spontaneous pneumothoraces from these ruptured apical blebs. So this man was also, this man is of Chinese origin, I think was born in China. Okay, so spontaneous pneumothorax and then re-expansion edema. Then I wanted to show you a couple of diaphragm cases. And this is a man with COVID. This radiograph was taken back in March when he came to the emergency room with COVID. So he has pre-existing heart disease. He does have a defibrillator in place. I don't have his age right off. But at this point, he's got low lung volume, but the height of the diaphragm is pretty similar on both sides. And this was another admission radiograph or ER visit radiograph when he was first diagnosed with COVID. So his lung disease is COVID. And then if we skip ahead a few months, he's recovered from COVID, but he now has elevation of the left hemidiaphragm. Here's his elevated left hemidiaphragm with the stomach bubble way up here. And the elevation goes all the way to the back, which suggests when the elevation goes all the way from anterior to posterior that it's paralysis and not something like eventration, which tends to go back to normal height posteriorly. So this is paralysis. At the time this case occurred, I looked up cases of, I wondered, can COVID cause diaphragm paralysis? And there was no literature on it. So I looked again, because this man came back into our system in the last few weeks. I looked again, and now I found 20 case reports of COVID-related hemidiaphragm dysfunction. So, one of the neurologic manifestations of COVID is phrenic nerve involvement, and therefore potentially phrenic nerve paralysis or weakness. Here's what CT looks like in the course of this, and we'll see that there's pretty dramatic thinning of the posterior diaphragm muscle on the left. And one of the things that occurs with this atrophy of the muscle is sometimes you'll see little specks of fat in the muscle. So the normal diaphragm muscle doesn't have a lot of fat in it, but as it atrophies, you'll start to see a lot more fatty replacement of muscle tissue. So you get this fat infiltration in addition to the thinning. And his current radiographs are here. So he was back last month, and you can see that, especially with his lying in bed like this is last month, a year after we had that earlier imaging. He's got even more elevation when he's in bed. So putting a person supine, particularly if they have obesity in their abdomen, will exaggerate the elevation from a weak or paralyzed hemidiaphragm. So putting the person supine is another stress test, not just sniffing, for showing hemidiaphragm elevation. So he's still got it, it hasn't gone away. So COVID is a cause of diaphragm dysfunction by affecting the phrenic nerve. And let's see. This man, I don't have an early chest radiograph on him, but this man has a elevated right hemidiaphragm. This is an outside case, an outside CT at this point. And he does have this elevation. They didn't have a clear-cut cause for his right hemidiaphragm dysfunction. They said it was paralysis. Let's look at the cross-sectional imaging and check out the diaphragm muscle. You can see that there is some modest thinning, but not really the same degree of atrophy that we saw in that last case. Normally the posterior muscle on the right crus, is thicker than the left. And you can see that in his case, that is not true. The left is thicker than the right. So this is abnormally thin. It should be thicker on the right than the left. So his is not that way. So he does have this thinning, but it's not really complete atrophy. So, just looking at this, I would say, well, it's a little thin on that side, but it's not really atrophied, and therefore there is a chance that this is going to get better. It's, it might be weak, but it's not paralyzed. There's still reasonable thickness to this right hemidiaphragm. Now, I hope I can show you the sniff test. So here is, let me show you radiographs on this guy. This is an early radiograph on the same guy we've just been talking about. Notice that once again, the elevation goes all the way posteriorly, unlike eventration where it will dive posteriorly to get back to normal height. It stays elevated all the way back. That's great for paralysis or at least weakness. And then the current radiographs show restoration of normal height of the right hemidiaphragm. And on lateral view, everything's down at the same level. So he did recover. So when I get these cases of diaphragm dysfunction and I do sniff tests, I look at all their CT imaging and everything like that. And yeah, I will often say that the preservation of some muscle thickness implies the possibility of recovery because it's not completely denervated. And that panned out nicely in this case. So it's an example. I think I can show you the sniff test on him. And so this is AP standing, and you can see that he has vigorous function of the left hemidiaphragm. If it moves from one rib to the next rib, if it's one rib interspace, I consider that the lower limit of normal, and his exceeds that. But he's got decent excursion on the right. So he takes a couple of deep breaths, and then he's going to sniff, and you'll see that when he sniffs, there we go, he actually gets paradoxical motion of the right hemidiaphragm. You can see that the left goes down and the right is sucked up by the vigorous action from the left. And then if we look at a lateral view, which is always essential in these things to help distinguish from eventration, you can see with a deep breath, he doesn't get much excursion. There we go. He's got some excursion of the right, and it's particularly good posteriorly. So he gets about half of vertebral body excursion. He's got much more excursion on the left. So you have to look at the lateral view on these things. Now watch what happens when he sniffs here. If I can make this happen, you'll see that he gets paradoxical motion of the anterior aspect of the right hemidiaphragm, but posteriorly it actually holds. It doesn't jerk up posteriorly when the right jerks up. So he's got enough function on this right side that he can resist the the sniff maneuver, which is sucking the right hemidiaphragm upward anteriorly. Posteriorly, he's got enough muscle function. So this was another indication that he has weakness, but not paralysis. So paradoxical motion does not equal paralysis. Paradoxical motion indicates relative weakness compared to the stronger side. And he actually is able to resist that posteriorly on the right. So, from the sniff test, I said this is moderate weakness, but this is not paralysis of the right hemidiaphragm. So please note, paradox does not equal paralysis, it equals relative weakness. Okay.
And was there a potential etiology for this temporary hemidiaphragm muscle?
No, they're calling it idiopathic.
Okay.
Chances are it's something in that spectrum, a Parsonage-Turner, which is thought to be an inflammatory condition, sometimes post-viral or something like that, where, but the people with classic Parsonage-Turner will have shoulder or neck pain that precedes the weakness of the hemidiaphragm on that side. He didn't have a prodrome like that would help point to that, but maybe it's just a form frust. Or, so these idiopathic things are considered, maybe it's post-viral, maybe it's some other inflammation and so forth. But it's a good result. So, checking out that muscle thickness is very helpful in predicting the possibility of recovery.
Yeah.
And then observing that there's still some residual strength, that it's not, it's not absolutely paralyzed is also helpful.
Yeah. How much time, David, elapsed between those two radiographs and the diaphragm coming back down? Do you recall how long that took to sort of resolve itself?
I think it was several months. I don't know whether it was
Okay.
6 months or a year or something like that. When I post it, I'll have the dates visible.
Okay.
I guess we could go. Yeah, can we go back to it? It's It's too hard for me to go in reverse here. I
That's
will
fine.
mess up if I try to do that. Okay, this person has a subtle azygos lobe up here on this radiograph, and then on CT, here we have the azygos vein, and then here we have the fissure. So this vein belongs in the fissure, and it's not there. So this is a case of empty azygos fissure. We do have an azygos lobe, and we have the vein somewhere else. Now, this is an outside patient, and this is all outside imaging. This man has a complicated history. He's got chronic renal failure. He's got other problems too. Don't have any surgical history on him to know whether he ever had a pneumothorax or a pleural effusion. Would have had, that he could have had lung collapse, and then when the lung re-expanded, the little thumb part of the azygos lobe didn't end up going back where it should, and it got caught. But Sudhakar showed me this case of empty azygos fissure. So it's usually the result of something that has caused lung collapse on this side, either effusion, evacuation of effusion, or pneumothorax. The azygos lobe comes out from the pocket, and then when the lung re-expands, it ends up re-expanding outside the pocket. In the other situations I've seen, the azygos fissure has been compressed medially after, when I've seen azygos, empty azygos fissures after lung collapse has resolved. I have not seen it hanging out there to the side, but there you go. Does anybody have a better explanation for this?
No,
Again,
I've seen a couple like that. One was after pneumothorax, and one was after I think of VATS, where they dropped the lung, and I think it just pops out. But the ones I've seen, the fissure stays in its place. I don't know. I think it's been reported spontaneously too.
Okay.
Maybe during growth or something, it as the patient grows and the lung grows, maybe it pops out slowly.
Got it. Okay, I have one final case, which is not remarkable, but just has a constellation of findings. This woman has LAM, and she has had pleurodesis because of recurrent pneumothorax on the left. So that's why she's left with this pleural thickening. She also earlier, and I don't have any images in our system, had a angiomyolipoma of the left kidney and has had resection. So her findings are classic. She's got thin-walled, very regular, very clean-looking cysts throughout the lungs, going all the way down to the bottom. Unlike Langerhans cell histiocytosis, she has pleural thickening with deposits of talc here from her talc pleurodesis. Big blob of talc back there and pleural thickening. And then in the upper abdomen, we don't get far enough, but she's got some clips from her left nephrectomy because of the angiomyolipoma, which I think must have bled for them to have resected it. So everything you could expect from LAM except chylous effusion. So that's the one element that's missing here. Okay, guys, thank you.
All right, David, that was a nice diaphragmatic tutorial. I like that. Okay, let's see. Okay, so Travis, this is my avulsed IVC case. This was a bad motorcycle or a motor vehicle crash or something, like high-speed trauma. And you can see it on the abdomen CT right in the same location. There's this unhappy looking IVC and very unhappy looking liver, probably the hepatic veins are avulsed as well, lots of blood in the belly. Interesting on the delays, there's all this blood in the, like subcapsular blood, and there's active bleeding into the peritoneum, and you can see there's the abnormal IVC. What's kind of scary is if you just have a chest CT, it's really hard to see that abnormality right there because we're just too early. And because there's not the usual little bit of reflux, probably because, I mean, I bet the pressure in the abdomen has gone up, so it's preventing that from happening. So had some irregularities of the aorta, but they were atherosclerotic. So that's the only time I've seen an IVC avulsion or injury.
Nice.
Yeah. All right. So let's see. So Howard, this is, I managed to get this down.
Okay.
This is the case we had. So COVID has been on a ventilator recently and now off, developed some barotrauma, pneumomediastinum, has a little pneumothorax, has some subacute gas that's been increasing. And then this was more apparent to, well, it was new today on the radiograph, and it looks like pneumoperitoneum, right? It looks like a continuous diaphragm sign. And so here's an abdominal CT done just a little while ago, and you can see what her lungs look like. So she's got that sort of somewhat advanced acute lung injury, not a lot of fibrosis on this image, but on a recent chest CT, there is some reticulation, a lot of subacute gas tracking in the mediastinum. And then as we go down, exactly what you showed.
Yeah.
I mean,
Yeah.
it almost looks like the same case. Interesting. Yes. And I guess this is tracking along the paracolic gutters.
Retroperitoneal.
Yeah.
In the fat.
Yeah.
Yeah, exactly.
So that's that case. All right. This is kind of a crazy case. So this is an elderly patient who has, let's see, is this the one? I'll show this one first. This is the first scan. So has this aortic problem, lots of atherosclerosis, and you can see the wall here looks kind of thick. And it makes you wonder if there's an intramural hematoma or if this is atheroma. It's awfully smooth to be plaque, and there's the intimal calcification. So to me, it looks like an intimal hematoma. This was all from the outside, so I don't know what they said or did, but the patient was eventually transferred here because this is about, let's see, about a little over a week later, and patient was developing fever and not doing so hot. And so the CT looks like this, and we can see there's actually increased thickening of the wall of the aorta, and there's gas in the wall of the aorta, little bubbles of gas, which is not good. So this went to open repair because this is a presumed infected aorta. They called it a mycotic aneurysm. I'm not sure if that really qualifies as that. I guess I wonder if it's an infected type B intramural hematoma, but whatever. And this actually grew out E. coli. But I can't recall seeing a case with gas in the wall of the aorta like this. Let me go coronal. Have you guys ever come across something like that?
Yeah, I'm going to try to show a case similar to this maybe next week or the week after, but it reminds me of a case that I've been waiting to get information about that had some similar features.
Mm-hmm.
But I can't remember whether in that case there was potentially a fistula from the esophagus, so I don't know. I can't quite remember at the moment.
This one did not involve the esophagus.
There's no fistula to esophagus or lung.
So Jeff, had there been surgery on this person? I think I missed some of the history that you gave at the beginning.
Yeah, they were again transferred here. So as far as I know, there was surgery after the CT where they did a washout and a primary graft repair, and then they cultured this tissue and it grew out E. coli.
Wow, that is.
So I presume it's seeded from somewhere, maybe from a UTI or something. I don't have all the records because it's a fairly incomplete I mean, I don't have the full notes from the outside place, but I've just not, I mean, it's a rapid change, but I've not seen gas in the wall of the aorta like this other than with a fistula. And as far as I know, when they were in OR, they did not identify any fistula. So a weird aortitis. All right. So this is a nice case. This is a 20-something-year-old young guy who presented with chest pain, and you can see there's a large mass in the mediastinum, and we've got several lung nodules on the right. Here's the lateral, so it's located anteriorly. So at his age, thymic neoplasm is pretty low on the list. Lymphoma would be a little unusual, but got to get a CT scan, and they did, and he's got this quite ugly looking mass, very heterogeneous. You see it's invading the mediastinum. It's also invading the brachiocephalic vein here into the internal jugular vein as well, subclavian area. So no, a little bit of calcium in it, a little bit of cystic stuff. So a germ cell tumor is a good candidate. And then of course there's some look like metastases. And this was biopsied and it was a non-seminomatous germ cell tumor. He's got some PE too. I wonder if some of this is maybe even embolic tumor from that vein invasion, because it looks pretty ugly looking, not so streaky like typical PE, but who knows. Anyway, he got some chemotherapy. So here he is 3 months later after some chemotherapy, and you can see this is shrunk down quite nicely. A lot of that invasive component is gone, and just the cystic component, the dystrophic calcium, are still there. Whatever that we've taken out the anterior basal segment in the right lower lobe. So whether that was tumor thrombus or bland thrombus, it's gone. So he subsequently then had resection, and now looks something like this, and has been cured of this. So these germ cell tumors typically are quite chemosensitive. They can be very locally aggressive, but it was nice to have sort of see the sequence of this, and then any immature components sometimes will be leftover mature components, or the mature components, probably the cystic component in here that I showed that was left over, didn't go away, and then they resect all of that. And so if you can get all of that out and you have a good response to chemo, they can have a good, this little bit left too, you can have a really good outcome. So he's about a year out now from his surgery, and there's no evidence of disease anywhere.
That's a great result.
Yeah. Okay, this is kind of a challenging case. So this is a woman in her 40s who was diagnosed with a colon cancer several years ago and was treated with local surgery and chemotherapy post-op, but had relatively early stage disease, I think like stage 2 or something. Then she presented with lung nodules that were ultimately shown to be metastases. And you can see these nodules are like sort of soggy looking Cheerios. They're kind of not quite cystic, cavitary, whatever you want to call them, but they're not solid. And she has a whole bunch of them. And so these have been there for now several years. And she's been on a variety of chemo regimens and bevacizumab and some other type targeted therapies. And they were kind of percolating along. And then, let's see, this was a little bit later. We could see they're starting to get conglomerate a little bit, form these larger cavitary spaces, particularly this left lower lobe. You can see them kind of getting close together. And then in the last, say, 6 months or so, let's see if I can find the right one, they started to change a lot more. And in this left lower lobe, all of a sudden they got really thick, and this cavity got really complex, and there's a lot of debris in it. And some of the walls are starting to get thicker and have a little bit of fluid level. And she came in, she was admitted to the hospital over the summer, kind of ill, and they ended up bronching her, and they recovered Mycobacterium avium complex. So a super infection with MAC in cavitary lung disease from metastatic colon cancer. Now it gets a little more interesting. So she got, let's see if I can find it. So she is now on, and she had good susceptibility. So she's been on rifampin, ethambutol, azithromycin, and I think Zosyn. And then this is her most recent scan, and she's developed now some bronchiectasis in this cavity, and it's become even more complex. And I'm curious what you guys think. What changed dramatically, though, is she developed all of these tiny nodules.
Yes.
Like everywhere. And some of them look a little tree and bud like central lobular. I was struggling to decide if they were all central lobular or if maybe it was more of a miliary pattern. They're definitely not perilymphatic, but I think a lot of them are central lobular. The fact that some of them branch, like this one here, and it's nice central lobular. There's a few along that septum there, but we were kind of figuring out, is this all new tumor that developed in the course of a few months? Probably not. Is this another infection? Is this histoplasmosis? She's only on bevacizumab at this time, and plus her antibiotics. Or is this just spillage from this sort of evolving cavity here that's now got bronchiectasis? So with the MAC sort of being treated, is there just developing fibrosis, and maybe between the two there's some progressive cavitation, and it's just spillage. But it's so diffuse, I really don't, and I guess it's more lower lobe, not thrilled with it all being spillage.
So Jeff, she doesn't have pulmonary hypertension here. She does have a catheter in place.
Yeah,
Is she's probably on painkillers. Any chance that this is excipient lung disease?
I don't think so. I mean, she's had that
clean-
port for a long time.
What does her PA look like? Does she have
It's
hypertension?
normal.
Yeah. Okay.
Yeah,
I think she could well be colonized with, say, Pseudomonas. You can get a diffuse small airways sort of thing. It's basal predominant, which is good for infection settling down at the bottom.
right.
Just because she's smack down there doesn't mean she doesn't have other bugs like Pseudomonas.
Right.
And the other thing is, it could even be MAC that's disseminating in those small airways.
Yeah, I wondered that, or if it is just, yeah, I mean, she's not acutely ill. She's tolerating her meds, so I didn't know if it was just spillage of debris and bugs, but not really worsening of the infection. Because I didn't think it was necessarily a worsening infection, or was it just a redistribution of all the exudate? But they're so uniform. Go ahead.
Yeah, I mean, I think MAC makes sense. You're seeing a bunch of small nodules, which would just represent the granulomas from MAC, and then the cavitary fiber, the fibrous thickening around it. I mean, I think, and then the fact that she's not acutely sick makes MAC makes sense there, right? Also,
Okay.
with,
Yeah, I don't know what they're gonna, if they'll bronch her or if they're just gonna give it some time. But if I get any follow-up, I'll let you know. But I was kind of curious. This is, I think, the first time I've seen super infected metastases, but they've been around for about 3 years, so she's had time to let something brew in there, and they've been held in.
yeah, that was really interesting with how the cavities got it. Yeah.
Yeah, and it's the only site of disease.
That was cool.
Yeah. So the
Wow.
bevacizumab seems to be holding it in check mostly. All right. I did that one. I did that one. I did that one. Yeah, that's it. Okay, and it's the hour. So thanks, everyone. Those were fantastic cases this week.
Yeah.
All right.
Great. Thanks, everyone.
Yep. Take care.
You too.
Bye-bye.
Bye, everyone.